So with that, I would like to call upon Dr. Sory Diawara. He is a physician and an epidemiologist from the Malaria Research and Training Center in Mali. Welcome.
Okay. Hi, everybody. Thank you for the organizers. Now, I want to share with you our research related SMC extension to children from 5 to 10 years in a pilot district in Mali. As you know, malaria remains a big challenge in Mali. As you know, the prevalence is about 19% from children under 5 years, and the mortality rate about 4% in school age. In 2012, we recommended SMC as the best strategy to control malaria, and we conducted a pilot study in Kita area. In 2010, only one district was covered by SMC. Now we have 65 districts in Mali covered by SMC strategy. How was our objective in this study? We want to assess the impact of SMC on malaria prevalence and incidence among children from 5 to 10 years, to assess the feasibility, adherence, and coverage, to conduct an assessment for post-analysis to SMC extension for school age. The two districts, Kita and Baflabe, had a similar characteristic about community, geographic, and epidemiologic characteristic. We did a non-randomized pre and post design with Kita intervention district and control district for Baflabe. SMC drug was monthly administered to children from 5 to 10 from July to October, 2 years ago. And we did a cross-sectional survey to test malaria and anemia rate. We reviewed data from health center, and in Kita we did cross-sectional study for adherence after each run of SMC. For sample size, we assume a 25% district in Kita for parasitemia prevalence and a power of 18%. A total of 2,432 children were enrolled in this study. Our results. SMC coverage among school-age children was about 19% for the 4 rounds of SMC. About side effects after SMC drug administration, diarrhea, drowsiness, and vomiting were the most common observed. To protect from malaria, children slept under ITN about more than 95%. Before intervention and after intervention, we have some finding about malaria prevalence. The plasmodic index is was similar in the two districts before intervention. After intervention, malaria plasmodic index decreases in intervention district. About routine data collected in health centers, we have a reduction for severe malaria about 21% and severe malaria about 62% after intervention. The drug resistance marker was very low before intervention and after intervention in the pilot district. In the two districts after intervention, the resistance marker prevalence was still low. For cost analysis, we consider some topic about drug supplies, impression, orientation, and distribution. These parameters permit us to assess the cost of SMC. A total of children covered by SMC and costs engaged for this activity, we have 3.35 to cover for each run children from 2 months to 10 years. From 2 months to 59, we have 3.05. Only school age, we have 3.56. The difference to extend SMC to school age, we have 0.30 for each child and for each run. Our study was limited by this parameter. Before and after intervention, we lost children to follow-up. And the timing of blood collection, July 2007 and November 2008, were different. And malaria seasonality differed from July to November. The age group used by DHS system is not the same in our study. In conclusion, we found the same characteristic about malaria prevalence plasmodic index before SMC campaign. And after, we observed 40 reduction in parasite prevalence, 21% reduction of uncomplicated malaria, 62% reduction in prevalence of severe malaria. SMC coverage rate in the pilot district was very high, and implementation cost was not varied from 5 to 10 years, and 85% of additional cost was due to drug acquisition. And we recommended extension of SMC to school year. We want to acknowledge this actor. Thanks. Okay.
So we have a few minutes, so if there are any questions specific to this presentation, we'd be happy to allow Dr. Sory to take them now.
I have two questions for you.
Okay.
One is maybe a yes/no. Do you have any data about gametocytes?
About?
Gametocytes.
Gametocyte.
The other is, I was a little bit surprised to see a dramatic decrease in severe malaria. What is the usual age for severe malaria in these areas?
We have data on gametocyte in this study, but we don't show because with blood smear, we count gametocyte. And I think one of my tables show this. Yeah. Above the shift of severe malaria. Now we observe a shift from under 5 years to 5 to 10 years. We observed it before. Now with SMC, we have the shift of severe malaria in this age group. With SMC now, in the pilot district, we observe low prevalence of severe malaria in this age group.
So I have another question for you. So this study was completed almost a year ago, and you recommended to the ministry that this strategy should be taken up. So I'm curious if they have already implemented it this year, or if that is a future plan. And if they have implemented it, I know you don't have the data, but if they are doing any monitoring to assess impact as that program is scaled up.
For extension SMC to school age, we think it's necessary to monitor and to extend the district step by step, not only the total of the district. Where the malaria is more prevalent, we can start with this area and progressively to other area.
I just want to add on the question of Julie. Yes. So this year we didn't do SMC for 5 to 10 years, but in the coming next year, we are going to extend SMC from 5 to 10 years in Sikaso district. So I just want to add that one.
Thank you.
So we hope that probably our other partners, Global Fund and the Ministry of Health, is more likely to extend this strategy in many districts. This was just a pilot done by PMI.
In 2020.
Starting 2020, we are going to have the SMC in Sikaso at many districts, not only one. Thank you.
Thank you. Right.
Yeah, thank you. Just one question. I noticed your LLIN use rates seem to be really high in the school children. I wonder how you've been able to get them up above 90, 95, because we've not seen a lot of that, in Uganda, where I come from. So.
Because in Mali, we have a mass campaign for ITN distribution every 3 years, funding by PMI. Yeah.
Maybe just to clarify, I think in Uganda we've had as well 2 universal coverage campaigns. But when we look at, coverage and use, especially in school children, we found that they did not use nets as much as we would anticipate. And yet, from your presentation, it looks like the use is up above 90. So I'm just wondering, maybe we could have some lessons to learn. How have you pushed it?
It's a great topic, and I think maybe it's something we can address in the group discussion in the end about interventions and how they get to school-age children. Thank you.
Thank you so much, Dr. Sory. That was an excellent presentation.